introduction. So I will go ahead and move forward with that. Selena, before I get going, do you want to say anything?
No, I will just remind everyone at the end when our next meeting is. So do go ahead, Rachel. Thank you.
Okay, wonderful. Well, it is great to see everyone. This is our first Netchatter meeting of 2023. Wonderful to see everyone's faces and to have everyone together again. And we are in for a treat today. Our speaker will be Dr. Raquel Martins. She's a consulting endocrinologist at the Portuguese Oncology Institute and an assistant professor at the Faculty of Medicine at the University of Porto. Her research interests in her talk today will be focused on paragangliomas and pheochromocytomas. And she has researched both clinical biological characteristics of the SCHX mutated tumors, psychological impact, and living experiences of patients living with these tumors. So we are honored and very excited to have Dr. Martin speak today. And with that, I will give her the floor.
Thank you very much. Hi, everyone. It is a great pleasure to participate in this Netchatter. And as a doctor treating NET patients every day, I would like to thank you for your work. So I will share my presentation. Please tell me if you can see it properly. Yes?
Looks great.
Thank you. So I will speak about these peculiar neuroendocrine tumors, pheochromocytomas and paragangliomas. This image shows the places where these tumors can appear. As you can see in a lot of parts of the patient's body, and pheochromocytomas and paragangliomas are histologically similar. So the anatomical origin is usually used to classify them. We used to use the term pheochromocytoma to describe the tumors that appear in the adrenal medulla, and paragangliomas for the others. But the WHO classification of 2022 classify all these tumors as paragangliomas. In the literature, you will always find the designation pheochromocytoma, and this tumor in this localization has some peculiarities, so I will use this designation during my presentation. As other neuroendocrine tumors, they are rare tumors, but the incidence is progressively rising. So all these tumors have metastatic potential, and there is no risk stratification histological scoring system that is endorsed to distinguish the biological aggressiveness of these tumors. So previously, the designation malignant pheochromocytoma and benign pheochromocytoma were used, but we do not use it anymore because every tumor can metastasize. So we replace that designations for metastatic pheochromocytoma or paraganglioma when they are associated with metastasis. And 20 to 15% of pheochromocytomas and 35 to 40% of paragangliomas are metastatic. What is very peculiar from these tumors is that nearly 40% of these neoplasms are associated with germline mutations. And you can see in this time scale in the more recent years, a lot of new gene mutations are being associated with these tumors. Nowadays, more than 20 PPGL predisposition genes have been implicated in hereditary PPGL. And in addition to germline mutations, nearly 30% of tumors have somatic mutations. So altogether, these are the tumors with the strongest genetic determinism. And so, for this reason, the genetic study should be considered for all patients with PPGL. And because the diagnosis of a germline pathogenic variant has important clinical implications for the follow-up of this patient, because the phenotype is different according to the mutated variant. And this is also very relevant for their relatives, because for asymptomatic mutation carriers, pre-symptomatic screening and lifelong surveillance is recommended for early diagnosis of associated tumors, and with that we expect to have a better prognosis. For some mutations, the mutation carrier will develop the disease only if he received the mutation from the father. So there are parent of origin effects on tumor risks, and this has to be considered in the genetic counseling. What we know today is that all these mutations can be grouped in 3 clusters. And the cluster 1 associated with pseudohypoxic signaling, the cluster 2 with sinus signaling, and cluster 3 that is more rare and usually associated with somatic mutations. And why this is important? Because it has implication for clinical practice. Because tumors associated with cluster 1 have cells are less differentiated and have a high risk of metastasization. And the opposite happens with the sinus signaling related tumors. And so identifying a mutation is also important to look for associated manifestations. Some of these syndromes, as you can see in this image, neurofibromatosis type 1 is associated with pheochromocytomas, is a classical syndrome associated with pheochromocytomas, and can be associated with these skin manifestations and other tumors that if we find the mutation, we can look for that. MEN2B is also associated with some phenotypic changes, and MEN2R is another syndrome that can be associated with pheochromocytoma, and von Hippel-Lindau disease, and in more recent years, another mutations, and as you see in the last slides, namely SDH mutations that are some of the most common mutations associated with pheochromocytomas and paragangliomas. And knowing the specific mutation is relevant to adjust, as I said before, the follow-up and even the treatment of these patients. As you can see here, the penetrance of these gene mutations, in the penetrance means that it relates to the percentage of mutation carriers that will develop the disease, because they may have a mutation but not develop the disease during their lifetime. So the penetrance is variable, and we know about these gene mutations in more recent years. So the evidence that we have about the penetrance and metastatic risk is still scarce, and this is a difficult problem in genetic counseling appointments and even for follow-up of patients. As you can see, the recommendations are different among the cluster 1 and cluster 2 gene mutations. One aspect that is important is that the SDHB mutation has a higher risk. It is a common mutation and has a higher risk risk of metastatic PPGL. And in Portugal, for example, this is very relevant because we described a founder SDHB mutation in Portuguese paraganglioma patients. So this is a problem for us because it's one of the more risky gene mutations. To understand more about the surveillance of these mutation carriers, we did a cross-sectional study involving the Portuguese oncology referral centers. We have 3 in Portugal, one in the north, one in the center, and the other in the south of the country. And we invited all the mutation carriers, SDH mutation carriers, to participate in this study. To be included, they needed to be subjected to biochemical and body imaging examinations that are recommended for their follow-up, for a complete assessment of the extent and spread of the disease. And so in our cohort, we found a huge prevalence of SDHB mutations. Of course, this study was done on oncology centers, so this may be related also with that. But among these SDHB mutations, the most common mutation was the one that has been previously described as being a founder mutation. So this is consistent with that knowledge that that mutation was particularly common. So among the patients, the mutation carriers that were identified due to the genetic testing, 22% were diagnosed with PPGL before they developed symptoms. And what we show was that when patients were diagnosed with tumors before they had symptoms, the prognosis was better. As you can see, the proportion of patients with metastatic tumors were more frequent when patients were diagnosed due to clinical manifestations. The results of surgery were better when they were diagnosed before they have symptoms, of course, and they were submitted less times to radiotherapy, and the disease status at the last follow-up was better when they were diagnosed before they developed symptoms. And what are the symptoms and signs that are associated with these tumors? As other neuroendocrine tumors, they can be functional or they can be non-functional. When they are functional, they usually are associated with hypertension, and this causes headache, sweating, and palpitations. This is a classic triad of symptoms. But other very common symptoms, as you can see in this table, can be associated with these tumors. We can do the diagnosis with biochemical testing, and we use this even for follow-up of mutation carriers. We use other tumor markers that we don't use in other neuroendocrine tumors, but we can also use chromogranin A. And as you can see here, even for biochemical testing, the mutation is important because the results can guide us to suspect of one or other mutation or clusters of mutations. We use anatomical imaging studies, CT scan or MRI, depending on the localization of the tumors. And we usually complete the study with functional imaging using PET-CT scans. But also here, the genetic study is very important to choose the right PET for these patients. It's not like in other neuroendocrine tumors. For some of these tumors, the mutation is very important to decide what is the functional imaging that we should perform. Taking into account all this information, we then individualize the treatment of our patient. And we can, as other neuroendocrine tumors, we like to perform surgery because this is the only potentially curative treatment. But when they are functioning tumors, we have to perform a combined alpha and beta adrenergic blockade before the surgery to prevent intraoperative hypertensive crisis. With some of these gene mutations, the metastatic risk is very low, but some of them are associated with bilateral tumors in the adrenal glands. If we remove both adrenal glands, we are leaving the patient with another disease, and they need to take a lot of medications to because they don't have adrenals. So for this reason, in some mutations from cluster 2, we do cortical sparing adrenalectomy. And this has to be done in centers with experience because are very rare situations. For some head and neck paragangliomas, radiotherapy or a wait and scan strategy can be good options to consider. Sometimes we cannot do a curative treatment, but surgery may be indicated to reduce the tumor because of the huge hormonal secretion causing a lot of symptoms. For advanced disease, systemic treatment is the option we have to do. And we have to consider, like in other neuroendocrine tumors, if the tumor is progressing quickly or slow, or the progression is slow. And so we have to decide going for chemotherapy, or we can use nuclear medicine treatments, for instance. And this, of course, depends on the functional imagings that the patient did before. So I can show you a patient. This is a patient with a bone metastasis. As you can see in the MIBG scintigraphy, we sometimes use this exam for other neuroendocrine tumors, but it is most used in pheochromocytomas and paragangliomas. It retains the radiopharmaceutical very well, and so we did this treatment, and as you can see here, the tumor marker was diminishing due to this treatment. After the initial treatment, we have some options, but we don't have very good treatment options for these patients. So that's why the diagnosis as quickly as possible to do surgery is important. So this is summing all this information and showing that even for treatment, the gene mutations are important to consider because some of gene mutations may predispose to a better answer to a specific treatment. For follow-up of affected individuals, again, the genetic information is important because due to the different risk of metastasization or of affecting other parts of the body, we do different follow-up schemes. And this is also relevant even for asymptomatic mutation carriers that we start to follow some of them when they are children. And the same here for another mutations. So, as you can see, these are very rare tumors with a lot of specific symptoms and treatments. And for this kind of tumors, the genetic testing is very important. So, how do our patients live with these tumors? We know from this study from Holland that quality of life is decreased in patients with paragangliomas. They assess the quality of life in patients with paragangliomas in asymptomatic mutation carriers, and doing some questionnaires, and they found that patients report a significantly impaired quality of life compared with their own controls, and mainly on fatigue and physical condition subscales. And compared with age-adjusted literature values, patients had significantly impaired scores on physical, psychological, and social subscales. And this was related to paraganglioma-associated complaints. The asymptomatic mutation carriers, the quality of life of them was not different from the general population. They also assessed coping styles in PPGL patients, because they thought this may be affecting quality of life, and they reported that this study cohort was more avoidant of problems and reported less expression of emotion, and they sought more social support. We performed this study to assess the previously examined psychological impact of the genetic testing, and we tried to identify factors associated with this impact. So with this huge cohort of SDH mutation carriers, some patients with disease, some without disease, some with metastatic disease, some with VETs in the family due to disease. We evaluated general well-being, psychological impact with a specific questionnaire related to this measure, and we also evaluated the factors associated with this impact, sociodemographic, clinical, and personality characteristics. And what we found that almost 30% of the sample displayed high global suffering associated with the genetic testing. The general well-being was affected in mutation carriers, with less quality of life levels and higher levels of anxiety and depression. And when we analyzed all the factors together, we found that patients that developed disease and had children presented higher distress levels, as well as patients with neuroticism and agreeableness personality traits. And these patients also had higher levels of uncertainty. On the opposite side, patients with higher levels of education and a higher consciousness personality trait reported more positive experiences related to the genetic testing. So looking at particular groups, among the group of affected mutation carriers, most never or rarely felt that genetic test result was made it harder to cope with their cancers. And 60% felt that the genetic test has made it easier to cope with their cancers frequently or sometimes. And those whose neoplasia was identified through pre-symptomatic screening felt that genetic test has made it easier to cope with their disease. Among the group who had children, 88% were worried frequently or sometimes about the possibility of their children getting cancer, and this was associated with some variables related to sociodemographic aspects or personality traits. 36% felt guilty frequently or sometimes about possibly passing on the disease risk to their children, and this was associated with having developed tumors with longer time since the test result, and again with neuroticism and lower extraversion personality traits. So, in summary, the mean scores obtained on micro subscales and total score was generally similar to the values reported for all other hereditary cancers. And the impact of the genetic testing was particularly negative for mutation carriers with stronger neuroticism, that is the tendency to experience negative emotions in the face of threat or loss, and agreeableness. That are patients with higher altruism, warmth, and affection. So the latter was unexpected, and this may be particularly these patients may be particularly vulnerable, perhaps because of their concerns for others, including their offspring. And these stress levels were higher for those who simultaneously have developed the tumors and have children. And clinical aspects of the disease only showed significant associations for participants with children. So this might reflect the fear exacerbated by having the disease of leaving the children behind, the suffering associated with the possibility of passing the mutation, thus the cancer risk onto the offspring, and the eventual difficulties of disclosing this information to them. The genetic tests did not make it harder to deal with the tumors for the vast majority of the tumor-affected patients, and actually made it easier for the affected patients who, at the time of the genetic test, were yet underdiagnosed. So this suggests that they consider the benefits associated with early diagnosis of a tumor that the genetic test provides. This genetic test seemed to have some benefits for more educated participants that might be more capable and less educated than the less educated participants of viewing the genetic test as an opportunity for early assessment and possibility of treatment. And positive experiences were also associated with a stronger consciousness. These are people that are well organized, diligent, and achievement oriented. And so they might adapt by focusing on the benefits of knowing it, adopting healthier behaviors, or engaging in the proposed medical screening and follow-up. We did an additional study to explore the experiences associated with the genetic testing using a qualitative approach. So we conducted semi-structured interviews to 38 mutation carriers with meaningful and rich experiences. And we then conducted a content analysis of these interviews. And we found that there were 4 ways of living, knowing that they carry a mutation, STH mutation, living as if not knowing, as if having nothing, preventing others that others go through the same, feeling privileged, or still suffering. The first feel less upset about the result than others, and they describe their negative reactions tend to be mild or quickly abated, or reacted with indifference to the test results. The seconds are a group of proband cases. This means they were the first of their families to be diagnosed with the mutation. So usually they had difficult situations of disease with metastatic disease, and they feel that the genetic test can help others, and they exonerated their parents' responsibility. The same happened in the third group. They prefer to know, and most reacted negatively to the information that they had a mutation, but they were able to assimilate the information and adjust their lives and to readjust their initial ideas. The fourth group was the group that still suffered. A lot of them said that at the time they did the genetic test, they didn't understand very well what that was. And the results meant a life-shake accumulation of bad news, and they had difficulty to exonerate the parents' responsibilities for passing on the mutation. So after the test, the first group feel that life goes on. They have no symptoms, and they keep saying that the mutation might not lead to the disease, and they can die from other problem. The second, maintain positive thinking, although they went through a lot during their lives, and the mutation even represent a special a special connection with other family members. The third group feel that it's an advantage to have the mutation because they have a special follow-up and they feel safer. And the fourth group suffer because they feel that the disease might appear or reappear. This is a thing that will accompany them through their life, and they keep being hyper vigilant regarding any body change, feeling that this is a new tumor. And some aspects have helped to attenuate this suffering. They value a lot the support from others. So they all feel would do the genetic test again, and most of the groups, the second and the third, only see advantage in the genetic testing. The first group feel that the genetic test might lead to suffering by anticipation, not for them but for other, and the group that still suffer refer the negative psychological impact of the genetic tests. They also talk about fecundity. It is not a common theme in the first group. The second group that suffered a lot fears that children might develop the disease. They fear that not being able to care for their children, and they fear experiencing more suffering associated with a pregnancy. And they would like to find a way for the gene to be blocked and not advance forward. But yeah, they also say, if I was going to select, I wouldn't exist. The third group, they also descend from mutation carriers, so they have a perfectly normal active life, and they discuss if conceiving naturally without trying to avoid the gene mutation transmission is a matter of egoism or not. The last group, they talk about deciding not to have children, or wondering whether the decision of having children would remain if they know about the gene mutation, and they consider medical assisted reproduction for if they have children, not for them not to have this gene in their body. So participants go through a dynamic process. This initial suffering in the face of the positive test can later remain as still suffering, or transform in a more positive view, like feeling privileged. Those who still suffer acknowledge several positive aspects but maintain negative feelings, and they might benefit the most from psychological support. The presence of the mutation when on the decision to have children among participants who experience greater suffering, whether caused by the disease or by the risk of developing it. And among the participants who accept the fact that they carry the mutation, this is like a special shared connection in the family. Had it been a factor of exclusion, these participants would not exist. And so, as take-home messages, I would say that PPGL are neuroendocrine tumors with a very high heritability rate, and associated mutations can be grouped into 3 different genetic clusters. Certain therapies may be more effective based on the underlying genetic mutation of the tumor, and for patients, personality characteristics and fewer clinical or sociodemographic factors are associated with more or less genetic test-related suffering, and patients' perspectives, positions, and emotions can be considered in genetic counseling for minimization of adverse events of undergoing the genetic testing that is so important for these tumors. And with this, I would thank you for your attention and leave you my email. And if you need to have any doubt, please send me email. Thank you.
Thank you so much, Dr. Martins. That was a fantastic presentation. At this time, does anyone have any questions?
I think there's one in the chat.
You're right. Okay. So in the chat, Simon has a question. He is on the train right now, but he was wondering if there was evidence of pseudohypoxia in addition to the SDHB mutation in primary/metastatic pheos and paragangliomas, and how much is known about the impact of the metastatic tumor niche compared to other tumor niches in, for example, pancreatic neuroendocrine neoplasms or other neuroendocrine neoplasms.
Thank you very much for the question. Yes, of course. It is not just for SDHB mutation that is associated with a high metastatic risk. Also, other mutations from cluster 1 are associated, that is associated with pseudohypoxia, are associated with a higher metastatic risk. For example, SDHA. But I just talk more about SDHB because it is more common. But yes, this is, and when we do the genetic testing, we do a lot. We search for all these genes, not for the most common. We nowadays in Portugal we are searching for 70 genes that are more common. So yes, we should look for others. I'm not sure if and I'm sorry for that, if I understand the second part of the question. And can you explain better? I'm sorry.
Simon may be on the train. I think
He's trying to reply, yes.
Oh, okay.
Yes, I'm sorry, maybe.
I think you may be talking about the pre-metastatic niche, maybe, because there is this concept about pre-metastatic niche, maybe, and how that impact in terms of tumor development, maybe, I don't know. But can I ask a question? Would that be okay? Yeah. So what are your thoughts about, like it has this concept, I am at the NIH, and as you know, we see a lot of pheoparas, and I work with Carl Patzak for that. And I mainly focus on metastatic pheos and paras, and we have clinical trials for that. But the question I have is about your thoughts about the high altitude. Is that a concept of this? Because I know that Brazil, you are in much higher altitude than this United States, and so the hypoxia concept. What are your thoughts about that, and how this affect? Is that something that is really important, and what do you tell the patients about that?
Yes, thank you. This is a very good question. Yes, that is about the altitude and the hypoxia, if this can be a driver for PPGL development. In the clinical study that we performed in our oncology centers, we search, for example, if the patients that smoke and how much they smoke, if this was associated with the PPGL development. It was not. So there are some initial studies that said that in high altitudes, the risk would be higher, mainly for the PPGL from the head and neck. But more recently, I don't know more evidence showing that this is, and even for patients that do sports associated with hypoxia, this was always with the patients, this was talk that may be a risk factor for the development of these tumors, but I don't know more recent evidence that this is indeed a factor to be considered mainly in this, for example, mutation carriers. So I usually don't talk about that because the evidence is scarce.
Okay, no, that's good. Thank you for that.
Yes, I don't have any study. We did not study these aspects. What we see in the clinics is that metastases usually are, with time, they can be different from the primary tumors, and associated with a different aspect, for example, in functional imaging. And so, but I don't, and this question is very important for choosing the treatments, but I don't have particular data on, more particular data on the specific case of pheochromocytomas and paragangliomas.
Okay. That's good. So I'm so sorry. Maybe one last question about your thoughts on immunotherapy, and do you feel like there may be a role of immunotherapy in the management of these patients? And I think we're still, learning about the tumor immune microenvironment of these tumors, and like in relationship to the hypoxia as well, the pseudohypoxia. But what are your thoughts about immunotherapy and or the management of these tumors?
Yes, I feel the same as you said, and we are, the evidence is very scarce, and when other treatments fail, we are trying to include these patients in clinical trials, and or we are trying to do immunotherapy, but yes, I feel that we need to know more about the same. I feel the same as you said, and my clinical experience with immunotherapy for these patients is very scarce. We thought about that in some difficult cases, but it didn't happen.
Oh, Heidi, you're muted.
I'm so sorry. I would say thank you so much. That's a very nice, but I think Simon say a follow-up. Are these tumors highly immunogenic? Yeah.
Yes, that was what we were saying. I feel these tumors are, as other neuroendocrine tumors, they can be very different. They can have an indolent behavior from many years, and we can sometimes just wait and follow up metastatic disease, or they can be very aggressive, and they can change. And I think we don't have enough evidence about these more aggressive cases, because they are rare, but I feel that in that case, immunotherapy may be a great option, but we still have less information, that less evidence than we need, that we should have.
Right.
Hi, do you hear me?
Yes.
Oh, thank you. So sorry for my technical issues early on, and thank you, Raquel, for your presentation. We have been talking a lot from the biological side of this type of tumors, but as you showed, as the psychological aspects of genetic testing are at least as on our side, on Portugal's side, they are not so often looked at. And what I would like to hear your opinion about is, do you feel that we look much more to the biological side, and when we do the genetic testing or genetic counseling, at least for some of the clusters that you showed us, we should also send our patients for to psychological support, because we do not do that as a rule.
Yes, thank you for your question. I think you talk about a very important point, because some of these patients of these studies were my patients, and I was not aware, and I give patients time for them to talk. I was not aware of their suffering. So and patients said that they thought that having the mutation mean that they will develop the disease. So they have a lot of misunderstandings that sometimes we try to communicate, but we are not be clear for patients. So yes, I think that genetic counseling is very important, and they need to understand what they are doing when they decide to go for the genetic testing, and when they receive the results, they at least some of these patients, and we can, for example, one of the questionnaires that we used, the micro questionnaire, it evaluates specifically the psychological impact associated with the genetic testing, and it is translated in my language. So maybe you can just use that and see the levels of distress, uncertainty, and identify the patients that will benefit from psychological support. Yes, I think maybe we must be aware of that, because we are telling patients that they have the risk of developing a disease. And as we show, the personality traits are the most important factors for this suffering associated with the genetic test results. So maybe I believe we should be aware of that and do more for these patients.
That's now a more personal question. Do you feel that these patients are more distressful than the patients with MEN1, because the penetrance is different? So, and we know that the patients with MEN1, they suffer a lot, but the point is, how do they cope with the pre-symptomatic stage?
Yes, MEN1 patients have a lot of manifestations, and they will develop some of them, like hyperparathyroidism. Some of the, as you can see, the mutation carriers receive the result and adapt to it in different ways. So there are, I have patients with metastatic disease that they live if they don't have the mutation. So patients are very different, so I don't want to generalize that, but some of these mutation carriers will not develop disease in their lives, a lot of them. So in that way, a group of these patients may suffer less from carrying this mutation these mutations when compared with MEN1.
Okay, thank you, Raquel.
Thank you.
All right. Does anyone have any other questions before we wrap up?
That was great. Thank you.
Thank you.
Right. Yes, that was an excellent presentation. Thank you so much for taking time out of your day, Dr. Martins, to come and speak with us and teach us all of this about para and pheos. It was very informative, and we are very thankful. And I would also like to thank all of our attendees for attending. Wonderful to see you all. I think us coming together and having these types of conversations, asking these questions and connecting is so important. And it's how we're going to continue moving the field forward. So thank you for attending. Selena?
Yeah, just to reiterate what Rachel said, thank you very much, everyone. And just the next date for your diary is Thursday, the 23rd of February, same time, which is 6 p.m. in the UK. Kate, would you like to just say who our speaker is next month?
I was going to say, are you bailing out of saying her name?
Yes, I am.
So yeah, it's Cynthia Ananadu, who is a researcher at King's College London. So she's a basic scientist who'll be talking about the research they're doing in their lab.
Fantastic. Right, it's lovely. Well, thank you very much, everyone, for coming. I think we'll close the meeting and we will see you all next month. And thank you very much for attending. Thank you, everyone. Thanks. Bye-bye.
Bye. Bye.